Welcome to the deep dive. Today we're tackling a really important, maybe sometimes overlooked area, renovascular disease or RVD.
That's right.
Basically, it's a whole range of problems that affect the plumbing, you could say, that supplies blood to your kidneys.
Good analogy.
Mhm.
And when that plumbing isn't working right, well, it can have some pretty significant knock-on effects throughout the body.
Yeah, absolutely.
The main worry with RVD really is that if your kidneys aren't getting enough blood, what we call renal hypoperfusion, it can, kickstart high blood pressure, hypertension, and it can also lead to a loss of kidney function over time.
And that combination is bad news.
It really is. That combination can then contribute to serious cardiovascular problems, potentially lead to needing dialysis down the road, and unfortunately, it does increase the risk of premature death.
So definitely not something to ignore. For our deep dive today, we're going to zero in on the most common type of RVD. That's atherosclerotic renal artery stenosis, or RAS. Basically, the arteries going to your kidneys get narrowed by the same kind of plaque that, clogs up arteries elsewhere, like in the heart.
And it's surprisingly common, especially as people get older. The sources we looked at mentioned it affects about 7% of folks over 65 in the U.S.
Wow, 7%. That's quite a few people.
It really highlights how prevalent this can become. Now, while atherosclerotic RAS is definitely our main focus, it's worth mentioning there are other causes of RVD, though they're less common.
Like what?
Things like fibromuscular dysplasia FMD, which is a completely different kind of artery wall issue, not plaque. Then you have tears in the artery walls, called dissections, bulges or aneurysms, trauma, certain inflammatory conditions, arteritis, and even some developmental abnormalities people are born with.
Okay, a whole range. But our mission today is to really get a handle on the key aspects of RVD, shining a spotlight on that atherosclerotic RAS.
Right.
And to guide us, we're digging into some really detailed chapters from a cornerstone text, Rutherford's Vascular Surgery and Endovascular Therapy.
Excellent source material.
So let's jump in. Okay, first things first. What actually causes these blockages or problems in the renal arteries?
Well, as we hinted, atherosclerosis is overwhelmingly the main culprit. The sources are pretty clear. If you look at patients referred for potential stenting of a renal artery, more than 90% of them, it's atherosclerosis.
90%.
Yeah. And even in studies looking back at patients who had open surgery, atherosclerosis was still the cause in something like 80%, maybe a bit more. Other things like FMD or dissection, they make up a much smaller slice of the pie. So really, when we talk RVD, we're mostly talking atherosclerosis.
So odds are, if there's a blockage, it's that familiar plaque buildup.
Okay.
But you mentioned FMD and dissections. Can you flesh those out a bit more? What are they exactly?
Yeah. Fibromuscular dysplasia, FMD, it's not about plaque at all. It's an issue with the structure of the artery wall itself. In the kidneys, it often affects the main renal artery and sometimes its branches, but usually further away from where the artery originates from the aorta.
Yeah.
And diagnostically, a key thing doctors look for on imaging, particularly with the most common type in adults, is this classic string of beads appearance.
A string of beads.
Exactly. The artery looks like it has multiple little narrowed segments, alternating with slightly dilated segments. It's quite distinct. Interestingly, though, when FMD affects kids, it's often a different subtype and might not show that beaded pattern.
Huh. String of beads. That's memorable. And dissections. That sounds pretty dramatic.
You can be, yeah. A dissection is basically a tear in the inner lining of the artery wall. Blood can get between the layers of the wall.
Ouch.
It can happen seemingly out of the blue or because of trauma, sometimes as a complication of endovascular procedures, or in people with really severe high blood pressure. And underlying conditions like FMD can sometimes make the artery more prone to tearing. Occasionally, a tear might even start in the main aorta and extend into the renal artery.
And the danger there is...
The worry is that the flap of torn tissue can block blood flow, sometimes completely, leading to kidney infarction where part of the kidney tissue dies from lack of oxygen.
Oh.
And even if it heals, the process can leave behind a narrowed area, stenosis, or cause a weak spot that bulges out, an aneurysm.
Right, so multiple ways these arteries can run into trouble. Now, we know that reduced blood flow to the kidneys is a major trigger for high blood pressure. Can you walk us through how that actually happens, the mechanism?
Absolutely. This involves a really crucial physiological system, the Renin-Angiotensin-Aldosterone System. You often hear it called RAAS.
RAAS, okay.
Think of it as the body's built-in mechanism for managing blood pressure and fluid balance. The story actually starts way back, late 1800s, with the discovery of this substance called renin in the kidney. But it was really experiments by Goldblatt in the 1930s that definitively linked reducing blood flow to the kidney with causing high blood pressure, and importantly, that it could be reversible.
So those early guys really paved the way.
They absolutely did. So what happens is, when there's a significant narrowing of stenosis in the renal artery, the kidney downstream senses its reduced blood flow, almost like it's sensing low blood pressure systemically.
Okay.
This triggers specialized cells within the kidney, near the filtering units, to release renin into the bloodstream. Renin then acts like an enzyme, kind of like a key starting a chain reaction. It finds a protein circulating in the blood called angiotensinogen, which is made by the liver, and converts it into angiotensin I.
Angiotensin I. Got it. That's not the final step, though, is it?
No, angiotensin III is sort of an intermediate. It then travels through the bloodstream, and mainly as it passes through the lungs, it encounters another enzyme called angiotensin-converting enzyme, or ACE.
ACE, like an ACE inhibitors.
Exactly the same one. ACE converts angiotensin-angiotensin II, often shortened to ANG2. And ANG2 is really the main workhorse, the primary effector molecule in this whole cascade when it comes to raising blood pressure.
Okay, so ANG2 is the main player. What does it actually do to increase blood pressure?
It works through a couple of major pathways. First, it's a very potent vasoconstrictor. It signals the smooth muscle in the walls of blood vessels all over the body to tighten up, to constrict. This narrows the vessels, increases resistance to blood flow, and boom, blood pressure goes up.
Okay, tightens the vessels. What else?
Second, it promotes blood volume expansion. It tells your body to hold on to more salt and water. It does this directly by acting on the kidney tubules, making them reabsorb more sodium and water back into the bloodstream instead of excreting it in urine.
Right.
And it also works indirectly. ANG2 stimulates the adrenal glands, which sit on top of the kidneys, to release another hormone called aldosterone. Aldosterone then also acts on the kidneys to increase salt and water retention.
Okay, so ANG2 is hitting it from both sides, tightening the vessels and increasing the fluid volume inside them. It's like a double whammy.
That's a perfect way to describe it.
Now, the sources mention a difference between unilateral RAS, just one kidney artery affected, versus bilateral, where both are. Does that distinction matter in how this plays out?
Oh, it makes a huge difference. If only one renal artery has a significant narrowing, that's unilateral RAS, the other kidney, the contralateral one, is still getting normal blood flow. And that healthy kidney can often compensate. It senses the overall higher blood pressure and the increased volume and responds by excreting more sodium and water, a process called pressure natriuresis. This helps keep the total body fluid volume somewhat in check.
Ah, so the healthy kidney tries to balance things out.
Exactly. But if both renal arteries are significantly narrowed, bilateral RAS, or if someone only has one functioning kidney to begin with and that artery gets narrowed, sometimes called Goldblatt volume-dependent hypertension,
Yeah.
then you lose that compensatory mechanism. Neither kidney can effectively get rid of the excess salt and water.
So the volume overload just builds up.
Right. And that leads to much more severe volume-dependent hypertension that can be harder to control.
That makes total sense. If both sides are struggling, neither can pick up the slack. Now, I recall reading that ANG2's influence isn't just limited to the kidneys and blood vessels. It affects the brain, too.
That's absolutely right. ANG2 can cross into the brain or be produced locally there, and it acts on specific brain regions involved in regulating the autonomic nervous system's control over blood pressure. It can influence thirst and water retention. It can sort of reset the body's blood pressure sensors, the baroreflex, making them less sensitive. And it can stimulate the release of other hormones like vasopressin from the pituitary gland, which also promotes water retention.
Wow, so it's got quite a wide reach. And the sources also mentioned something called the intrarenal RAAS. Is that like a localized version of the system just within the kidney?
Precisely. Researchers have found that many components of the RAAS renin-angiotensin ACE ANG2 receptors are actually present within the kidney tissue itself. This local or intrarenal RAAS can function somewhat independently of the systemic circulating system.
And what does it do?
Well, in situations like hypertension or poor kidney perfusion, this intrarenal system can become overactive. It can amplify the production of angiotensin right there within the kidney, contributing further to local vasoconstriction, sodium retention, inflammation, and fibrosis, all things that can damage the kidney over time. There's even some evidence suggesting renin might be present inside brain cells too, though its exact role there is still being figured out.
Fascinating, like a self-perpetuating cycle within the kidney itself. Now, is Angdoria always the bad guy here? I think I saw a mention of something called angiotensin 1 to 7. Is that different?
That's a great point. The system is more nuanced. Angiotensin-17 is another peptide hormone that can be produced, often from angiotensin-42 via different enzymes. And intriguingly, angiotensin 1 to 7 seems to have effects that often counteract the detrimental actions of Ang2.
Oh, really? Like what?
It tends to promote vasodilation and widening of blood vessels. It can have anti-inflammatory effects, anti-proliferative effects, meaning it might inhibit excessive cell growth, and anti-fibrotic effects, potentially reducing scar tissue formation. So it represents a kind of counter-regulatory arm of the RAAS, trying to maintain balance.
Interesting. So it's a complex interplay, not just one hormone running rampant. Now, this ongoing RAAS activation in high Ang2 levels, does that cause lasting damage beyond just raising blood pressure temporarily? You mentioned fibrosis.
Absolutely. Well, the initial trigger is the RAAS response to reduced flow. Chronic, sustained exposure to high levels of Ang2 leads to significant structural changes in the cardiovascular system. We're talking about promoting cell growth, hypertrophy and hyperplasia, inflammation, oxidative stress, and the deposition of fibrous tissue, basically scarring within the blood vessel walls and the heart muscle itself.
So the vessels and heart actually change shape.
Yes. This leads to what's called hypertrophic remodeling. The blood vessels become thicker, stiffer, less compliant. The main pumping chamber of the heart, the left ventricle, can thicken and enlarge to cope with the high pressure, but this eventually becomes detrimental. And the concerning part is that these structural changes can sometimes become somewhat fixed and may not fully reverse even if you later fix the renal artery stenosis. This can limit how much the blood pressure improves after an intervention.
Right.
Though the good news is that medications that block the RAS, like ACE inhibitors or ARBs, do seem to help reverse some of this remodeling over time, which is another benefit beyond just lowering blood pressure.
Okay, so fixing the plumbing is important, but you also have to deal with the downstream damage. Now, we've focused a lot on hypertension, but RVD can also directly cause kidney function to decline. That's ischemic nephropathy, right? How does that happen?
Exactly. Ischemic nephropathy refers specifically to the loss of kidney function resulting from renovascular disease, from that reduced blood flow. Kidneys are quite vulnerable because, unlike some organs, they don't have a rich network of backup blood vessels or collaterals. So if the main renal artery gets blocked suddenly, kidney damage can occur relatively quickly.
But it's usually more gradual.
In chronic RVD, yes, it's typically a slower process. The sustained reduction in blood flow, chronic hypoperfusion, lowers the pressure inside the glomeruli, those tiny filtering units. This reduces the forced driving filtration, so the kidneys become less efficient at filtering waste products from the blood.
So just not enough pressure to filter properly. But you also mentioned Ang2 and aldosterone contribute directly to the kidney damage too, not just the lack of blood flow.
That's a crucial point. The chronic overstimulation by Ang2 and aldosterone isn't just about blood pressure. These hormones actively promote kidney injury. They stimulate the production of pro-fibrotic factors, like TGF-beta, and growth factors that lead to scarring within the glomeruli, glomerulosclerosis, and damage to the tubules and the surrounding tissue, tubulointerstitial injury.
So it's a double hit, reduced flow and hormonal damage. And what about the atherosclerotic plaques themselves? Can they cause trouble beyond just narrowing the artery?
Yes, they can. Atherosclerotic plaques, especially complex ones, aren't always stable. They can rupture or erode, releasing tiny bits of cholesterol crystals and other plaque debris into the bloodstream.
Little fragments breaking off.
Exactly. These microemboli can then travel downstream and lodge in the smaller blood vessels within the kidney, blocking them off. This can cause small areas of kidney damage and contribute further to the overall decline in kidney function. It's sometimes called atherosclerotic renal disease.
Wow. So the plaque is dangerous in multiple ways. Now, something you mentioned earlier stuck with me, that severe high blood pressure from RAS in one kidney can actually damage the other, initially healthy kidney. How does that work?
It's a consequence of the systemic hypertension. The persistently high blood pressure generated by the kidney with the stenosis puts excessive strain on the delicate blood vessels, especially the glomeruli, in the contralateral kidney. Over time, this hypertensive injury can lead to damage, manifesting as protein leaking into the urine, proteinuria, and eventually a decline in that kidney's filtering function, shown by a rising creatinine level.
And can that damage be permanent?
Unfortunately, yes. If the hypertension is severe and prolonged, the damage to the contralateral kidney can become irreversible, even if the original RAS is eventually treated and blood pressure improves. This is why doctors are often cautious about using contrast agents for imaging if someone presents with very severe hypertension and signs of kidney damage until things are more stable.
A really important consideration. And I guess for many people, especially older adults with atherosclerotic RAS, the kidney problems they have might not be solely due to the RAS itself, right? There are often other things going on.
Absolutely. That's a critical point for understanding prognosis and treatment response. Chronic kidney disease is often multifactorial. Patients with atherosclerotic RAS frequently have other coexisting conditions that also damage kidneys. Things like diabetes, long-standing essential hypertension that was present before the RAS became significant, high cholesterol, maybe a history of smoking. All of these can cause intrinsic kidney damage independent of the flow limitation from the RAS.
Well, it's a mixed picture.
Exactly. And this is why if a patient already has advanced underlying kidney disease from these other causes, simply fixing the renal artery stenosis with a stent or surgery might not lead to much, if any, improvement in their kidney function. The damage is already done, so to speak.
Right. Doctors really have to weigh the potential benefit against the existing kidney health. Okay, let's shift focus a bit to epidemiology. How common is this condition? You mentioned 7% older adults, but it sounds like many people might have RAS show up on a scan without even realizing they have a problem.
That's definitely true. With the increasing use of cross-sectional imaging like CT and MRI for all sorts of reasons, we're finding RAS incidentally more and more often. Many of these individuals are completely asymptomatic. They have an anatomic stenosis, but it's functionally silent.
Why would it be silent?
Well, it could be that the narrowing isn't severe enough to critically limit blood flow and trigger that RAS response. Or maybe the body has adapted in other ways. Or paradoxically, sometimes the kidney with the stenosis is already so scarred and damaged from long-standing disease that it's not effectively producing much renin anymore, so it doesn't drive the hypertension.
So just seeing it on a scan doesn't automatically equate to a clinical problem. That makes sense, especially given how common essential hypertension and other kidney diseases are in the same older population that's likely to have atherosclerotic RAS.
Precisely. And you add in the fact that ANG2 levels can be elevated for other reasons like obesity or insulin resistance. And it becomes really challenging sometimes to determine if a visualized RAS is truly the cause of a patient's hypertension or kidney dysfunction. The imaging prevalence might overestimate the number of people who actually need an intervention.
It sounds tricky.
It really is. We still lack that perfect, non-invasive functional test to say with certainty, yes, this stenosis is the culprit, and fixing it will help. Often the only definitive way to know if revascularization will benefit the patient is, well, to do it and see what happens, which isn't ideal.
No, definitely not. So what do the studies tell us about the actual prevalence numbers in different groups? You mentioned the cardiovascular health study, the CHS.
Right, the CHS was valuable because it screened a large cohort of generally healthy people over 65 using renal ultrasound, regardless of whether they had high blood pressure. They found that baseline prevalence of significant RAS, usually defined as 60% narrowing, was about 7%. And in roughly 1 out of 8 of those cases, it was bilateral, affecting both kidneys.
And did they all have high blood pressure?
Interestingly, no. While hypertension was more common in the group with RAS, about 28% of them actually had normal blood pressure. And while most people in this study had normal kidney function initially, those with RAS were twice as likely to have an elevated creatinine level, suggesting some subclinical kidney impact.
So it can be there even without obvious symptoms. What about studies looking at people after death, autopsy studies?
Autopsy series have reported varying prevalence rates. One older study found RAS in only 6% of those under 55, but it jumped dramatically to 40% in those over 75, with about half of those being bilateral. Another series found RAS in around 22%. Of course, you have to consider that autopsy populations are biased towards people dying from conditions often linked to atherosclerosis.
True, the cause of death might skew the numbers. What about people already known to have blockages elsewhere, like heart disease or carotid artery disease?
As you'd expect, the prevalence is much higher in those groups. Angiographic studies where they inject dye to visualize the arteries performed on patients with known coronary, carotid, or peripheral artery disease have found RAS in somewhere between 22% and 40% of cases. There's a significant overlap, likely due to shared risk factors for atherosclerosis.
That makes sense. So the context really matters. What about looking specifically at people with diagnosed hypertension or kidney disease?
Again, higher prevalence. One study using ultrasound in newly diagnosed hypertensives found significant RAS in about 25%, and that rate doubled in patients over 60 who had severe hypertension. In patients with end-stage renal disease requiring dialysis, the reported prevalence varies widely in the literature, maybe from 9% up to 41%. It seems to depend on age, sex, and ethnicity, highest in the elderly, maybe surprisingly lower in African Americans on dialysis compared to Caucasians in some studies.
Okay, so it's definitely more common in those high-risk groups. Now, for someone who does have RAS, what typically happens over time if it's just monitored? What's the natural history? Does it tend to get worse?
Understanding the natural history is crucial for deciding if and when to intervene. Older studies, again using arteriography over time, followed patients managed medically. They found that the degree of stenosis progressed, meaning it got narrower, in about 11% to 35% of lesion. And for those that were already severely narrowed, about 10% went on to become completely blocked or occluded.
So progression is definitely possible. What about more recent data using ultrasound tracking?
A key study by Zierler and colleagues used serial duplex ultrasound over about 3 years. They found that for arteries starting with less than 60% stenosis, a significant number, 43%, progressed to high-grade stenosis. And for those already over 60% narrowed, 7% became completely occluded during follow-up.
Were there factors that predicted progression?
Yes, they identified several factors associated with a higher likelihood of progression: older age, higher systolic blood pressure, current smoking, female gender, and perhaps unsurprisingly, poor control of hypertension.
Okay, so the anatomical narrowing can worsen, but what about the functional consequences? The impact on kidney function and overall health?
That's the critical part, the functional progression. The ongoing RAAS activation, the persistent hypertension, the gradual decline in kidney function, these are what ultimately lead to the increased risk of cardiovascular events, progression to dialysis, and mortality that we worry about. Markers of this functional decline include that rise in serum creatinine, a fall in the estimated GFR, and also kidney shrinkage or atrophy, which can be measured on imaging like ultrasound.
And have studies tracked this functional decline over time in RAS patients?
Yes, several have shown this pattern. One study by Schreiber found that kidney function declined significantly over time in RAS patients, and interestingly, this happened even if the measured degree of stenosis didn't actually worsen.
That's interesting.
Another study by Dean followed medically managed patients with RAS and severe hypertension. They found nearly half had a significant rise in creatinine, and over a third showed a decrease in kidney length on follow-up scans. A study by CAPS specifically looked at kidneys with greater than 60% stenosis and found that 21% lost more than a centimeter in length over 2 years, accompanied by rising creatinine. This shrinkage correlated with the severity of the stenosis and higher systolic blood pressure. And some studies following medically managed patients reported that somewhere between 7% and 12% progressed to needing dialysis within about 3-4 years.
Those are concerning numbers, but didn't the CHS study find a slower progression rate?
Yes, that's an important contrast. Remember, the CHS cohort was generally healthier, older adults not specifically selected for hypertension or kidney problems. In that group, progression from any RAS at baseline to a critical stenosis over about 8 years was much lower, only around 4%.
So maybe slower progression in lower risk individuals with incidentally found lesions.
That seems to be the implication. Progression might be less likely or slower if you don't have the coexisting severe hypertension and other risk factors. But the key takeaway remains. Even if the artery doesn't rapidly narrow further, older patients who do have high-grade RAS, along with severe hypertension, are definitely at substantial risk for losing kidney mass and function over time.
Right. The overall clinical picture matters. Now, beyond kidney failure, what other health problems, what associated morbidity comes along with RAS?
RAS is strongly linked to broader cardiovascular morbidity and mortality. Patients with atherosclerotic RAS tend to have a higher burden of end organ damage. Things like that left ventricular hypertrophy we talked about, elevated creatinine, protein in the urine compared to patients with essential hypertension alone. Some estimates, like one from Mago cited in the sources, suggest RVD could account for as many as 10% to 18% of new dialysis cases among the elderly.
That's a huge contribution to the dialysis population.
It is, and it's also associated with other cardiovascular events like stroke and increased risk during major surgery. One important study by Conlon looked at patients with known coronary artery disease, CAD. They found that those who also had RAS had significantly lower 4-year survival rates, primarily due to an excess of cardiovascular events, not just kidney failure.
So having both conditions is particularly bad?
It seems so. And another analysis from the CHS participants, by Edwards and colleagues, reported that individuals with RAS had twice the incidence of new coronary events over just 14 months of follow-up, even after they adjusted for factors like hypertension and pre-existing cardiovascular disease.
Wow. So RAS really flags someone as being at very high cardiovascular risk overall. Okay, let's pivot to how patients actually present. We know many are found incidentally, but what are the common reasons a doctor would specifically screen for RVD?
Right, incidental findings on CT or MRI are common these days. But the classic indications that should prompt a doctor to order, say, a renal duplex ultrasound to look for RAS include severe hypertension, especially if it's resistant to treatment with 3 or more different blood pressure medications, unexplained kidney insufficiency, or declining kidney function, particularly in a patient who has known risk factors for vascular disease, and also for surveillance in someone already known to have RVD or who's had a previous revascularization procedure.
And you mentioned children earlier.
Yes, critically important. All children with unexplained hypertension should be screened for RVD. Remember, the blood pressure thresholds defining hypertension are lower in kids.
Got it. And when hypertension is caused by critical RAS, what does it typically look like? Is it different from regular high blood pressure?
Generally, yes. Renovascular hypertension tends to be more severe and often much harder to control with standard medications compared to essential hypertension. The sources mention one surgical series where the average preoperative blood pressure was sky high, like 2,104, even though the patients were taking, on average, 3 different antihypertensive drugs.
Wow, that's tough to manage.
Definitely. So in an adult with severe or resistant hypertension, the suspicion for RAS should be higher if they're older, have multiple atherosclerosis risk factors, smoking, diabetes, high cholesterol, or have a known history of blockages elsewhere, coronary artery disease, carotid disease, peripheral artery disease.
So look for severe resistant hypertension in someone with a vascular history. What about the link with kidney problems again?
In our experience, and reflected in the sources, ischemic nephropathy, kidney damage due to RAS, is almost always accompanied by severe hypertension. If someone presents with kidney insufficiency, but only has mild or moderate hypertension, the cause is more likely to be an intrinsic medical kidney disease rather than RAS.
Okay, that's a useful clinical pearl. And there's that specific situation with certain blood pressure meds.
Yes, the ACE inhibitor or ARB effect. A sudden acute worsening of kidney function right after starting one of these medications should immediately raise suspicion for bilateral RAS, or RAS in a solitary kidney. These drugs can interfere with the kidney's ability to maintain filtration pressure when flow is already compromised from both sides.
That's a big red flag. Can renovascular hypertension present more dramatically, like a crisis?
Absolutely. Unrecognized or poorly controlled renovascular hypertension can definitely manifest as a hypertensive crisis or emergency, with systolic pressures soaring above 200 mmHg. This can lead to acute neurological complications, severe headache, vision changes, confusion, stroke, intracranial hemorrhage, or cardiopulmonary issues like acute heart failure with fluid in the lungs, often called flash pulmonary edema.
Flash pulmonary edema, that sounds sudden and severe.
It often is. And remember, as we discussed, that severe hypertension from unilateral RAS can also injure the contralateral kidney, leading to proteinuria and elevated creatinine. In these acute severe settings, doctors need to be cautious about contrast imaging until the patient is stabilized.
Right. So it can range from subtle to life-threatening. What about the physical exam? Are there telltale signs?
The exam might reveal severely elevated blood pressure, maybe some peripheral edema or swelling. Listening carefully over the abdomen, especially in the upper quadrant, slightly off the midline, might reveal an abdominal bruit, that whooshing sound of turbulent flow through the narrowed renal artery.
Is that route reliable?
It's suggestive if present, but it's not always there, even with significant RAS, and sometimes bruits can be heard for other reasons, so it's helpful but not definitive. Other findings might include signs of generalized atherosclerosis elsewhere in the body. Checking pulses in the legs is also important. Diminished pulses could suggest associated peripheral artery disease, or rarely, other conditions like Takarasu arteritis, aortic dissection, or even aortic coarctation, or mid-aortic syndromes, especially in children.
So the exam gives clues, but doesn't clinch the diagnosis. What about lab tests? Any specific blood or urine findings point strongly to RVD?
The routine workup for any patient with hypertension usually includes a urinalysis, basic blood chemistries, like electrolytes, BUN, creatinine, glucose or HbA1c, a lipid panel, and an EKG. Elevated BUN and creatinine can indicate kidney dysfunction, which might be from RVD, but it's not specific. Many things cause kidney problems. The EKG might show signs of left ventricular hypertrophy from chronic high pressure. An echocardiogram can confirm LVH and is also useful in children to rule out aortic coarctation.
What about renin levels?
Measuring systemic renin levels in the blood is rarely helpful on its own for diagnosing renovascular hypertension. It's just too variable. It becomes more relevant when combined with selective sampling from the renal veins themselves, which is an invasive procedure we can talk about later. For diabetics, measuring urinary albumin excretion is important to assess for underlying diabetic kidney damage.
Okay. Are there other hormonal conditions that can mimic this?
Yes, important to consider mimics. If a patient has spontaneous hypokalemia, low potassium, or it develops easily with diuretics, that points towards primary hyperaldosteronism, or Conn syndrome. This involves excess aldosterone production from the adrenal glands. It's confirmed by measuring plasma aldosterone and renin levels.
Right.
And similarly, if an imaging scan done for another reason happens to show an adrenal mass, an incidentaloma, in someone with refractory hypertension, it warrants screening for both hyperaldosteronism and also for catecholaminergic excess from a pheochromocytoma.
Pheochromocytoma, what are the symptoms there?
Pheos typically cause episodic severe hypertension, often accompanied by the classic triad of headache, palpitations, and sweating. Patients might also describe panic attack-like symptoms, or pallor. Certain activities or medications can trigger these episodes. There's an increased risk in certain genetic syndromes, like MEN2 or neurofibromatosis type 1. The preferred screening test is usually a 24-hour urine collection for fractionated metanephrines and catecholamines, or sometimes plasma metanephrines.
Okay, so part of the workup is ruling out these other potential culprits. Now, let's really dig into the key diagnostic tool, imaging the renal arteries. Renal duplex ultrasonography, RDU, seems like the common starting point. What are its strengths and weaknesses?
RDU is indeed an excellent first-line screening test for RAS in most centers. Its advantages are significant. It's rapid, non-invasive, potentially very accurate when done by experienced technologists and interpreted by experienced physicians. It's reproducible, uses no radiation or potentially nephrotoxic contrast dye. It's safe if patients have pacemakers or other implants, and it's relatively inexpensive.
Sounds great. What's the catch?
The main limitations are that it's highly operator-dependent. The quality really hinges on the skill of the person performing the scan. It's also less reliable for visualizing other RVD manifestations like aneurysms, dissections, or detecting FMD accurately. And patient factors can interfere significantly. Obesity, overlying bowel gas, or even severely diseased shrunken kidneys can make it very difficult or impossible to get adequate views of the renal arteries.
So technically challenging sometimes. How is the exam actually done, and what specific measurements suggest a significant blockage?
Patients usually fast overnight to reduce bowel gas. They lie supine. The technologist first examines the aorta near the renal arteries, looking for aneurysms or plaque, and measures the peak blood flow velocity there. Then, they meticulously image each renal artery from its origin off the aorta out towards the kidney, recording velocities and waveform patterns at multiple points, proximal, mid, distal. They also measure velocities within the smaller arteries inside the kidney parenchyma, typically at the upper, mid, and lower poles, to calculate things like the resistive index, RI, and acceleration time, AT. Kidney length is also measured.
And the criteria for stenosis?
The exact criteria for defining a critical stenosis, usually 60%, can vary slightly. Our lab, consistent with many others, primarily uses a peak systolic velocity, PSV, in the main renal artery greater than 200 centimeters sec, especially when combined with evidence of turbulence in the flow just downstream from the narrowed segment. Some centers also rely heavily on the renal aortic ratio, RAR, comparing the PSV in the renal artery to the PSV in the aorta. A ratio of 3.5 is often considered abnormal. However, our lab hasn't found the RAR to be as consistently reliable as the direct PSV measurement. Some propose even higher PSV or RAR cutoffs for greater certainty.
What about those measurements within the kidney itself, the RI and AT?
Those look at the downstream effects. A blunted, delayed pattern of flow in the arteries within the kidney, specifically a slow acceleration time, often 100 milliseconds, can suggest a significant blockage further upstream in the main renal artery. This finding, when present, has a high positive predictive value in our experience, meaning it strongly suggests significant RAS. But its sensitivity is low where you can have RAS without seeing this delayed acceleration.
And the resistive index, RI?
The RI reflects the resistance to blood flow within the kidney. A normal RI is typically less than 0.7. While a very high RI in Angiotensin-0.8 can be seen with critical RAS, it's often nonspecific and more commonly indicates underlying intrinsic kidney disease, Nephrosclerosis, etc. There was a study by Radermacher suggesting that a high RI in 0.8 predicted a poor blood pressure response and continued decline in kidney function after revascularization, whereas those with RI 0.8 had better outcomes. However, this hasn't been universally adopted. And our center, like many, places less emphasis on RI for making treatment decisions about RAS itself.
Okay, so RDU is a valuable screening tool, but operator-dependent and has limitations. What about CT angiography, CTA?
CTA has become incredibly widespread for vascular imaging. Its main advantages are speed, excellent spatial resolution allowing for detailed 3D reconstructions, and the fact that it's generally less technically demanding to acquire and interpret consistently compared to RDU or MRA. It's non-invasive, apart from needing an IV for contrast.
What are the downsides?
The two main drawbacks are exposure to ionizing radiation and the need for iodinated contrast material, which carries a risk of contrast-induced nephropathy, especially in patients with pre-existing kidney impairment. The radiation dose from a typical renal CTA is higher than a standard X-ray, and contrast volumes are often in the range of 120–140 milliorder.
But how accurate is it?
Compared to the gold standard DSA, CTA has shown very high sensitivity, specificity, and accuracy, often approaching 100% for detecting significant stenosis in the main renal arteries. A huge advantage is that it also provides excellent detail about surrounding structures, kidney size, and parenchymal appearance, the aorta, other visceral arteries, which is invaluable for planning potential surgical or endovascular interventions.
So, comprehensive picture, but radiation and contrast risks. How does magnetic resonance angiography, MRA, compare?
MRA is another very useful non-invasive option. Its key advantage is the lack of ionizing radiation and often the avoidance of iodinated contrast, making it preferred in children, young adults, or patients needing frequent follow-up scans.
Limitations of MRA.
Scan times are typically longer than CTA, making it more susceptible to motion artifacts if the patient can't hold still. Spatial resolution generally isn't quite as high as CTA or DSA. Claustrophobia can be an issue for some patients, and it's incompatible with certain metallic implants. While it often avoids iodinated contrast, gadolinium-based contrast agents are sometimes used. However, gadolinium is contraindicated in patients with significant renal impairment due to the risk of a devastating condition called nephrogenic systemic fibrosis, NSF.
How accurate is MRA for detecting RAS?
Its accuracy for detecting critical RAS compared to DSA is generally excellent, similar to CTA. One potential pitfall is that MRA can sometimes overestimate the severity of stenosis compared to other methods.
Okay, so another good non-invasive option with its own profile. That leaves the gold standard, digital subtraction angiography, or DSA. Why is it still considered the benchmark?
DSA remains the gold standard, primarily because it provides the highest spatial resolution for visualizing the vessel lumen, the inside of the artery. Critically, it's also the platform that allows for simultaneous endovascular treatment, like angioplasty or stenting, during the same procedure.
Can you minimize risks with DSA?
Yes, techniques allow for using minimal amounts of contrast, and in patients with kidney insufficiency, carbon dioxide CO2 gas can be used as an alternative contrast agent, further reducing the risk of nephrotoxicity.
What doesn't DSA show?
Its main limitation compared to CT or MRI is that it primarily shows the lumen. It doesn't provide detailed information about the vessel wall itself or the surrounding tissues. Image quality can also be degraded by patient factors like obesity, bowel gas, heavy calcification, or patient movement. And of course, it's an invasive procedure.
Invasive meaning?
Meaning it requires arterial access, usually via the groin or wrist, with insertion of catheters. This carries inherent risks, including bleeding or vessel injury at the access site. Complications occurred in around 13% of patients in one large trial's roll-in phase. There's still the risk of contrast, nephrotoxicity, unless using CO2, significant radiation exposure for both patient and staff, and it's more labor-intensive and expensive than non-invasive tests.
So when is DSA typically used now?
Given the quality of non-invasive imaging, DSA is generally reserved for patients in whom a decision to proceed with renal artery intervention, stenting or planning for surgery, has already been largely made based on clinical grounds and non-invasive imaging. It's then used for definitive confirmation, precise anatomical mapping, looking for accessory arteries, branch disease, status of the contralateral kidney, condition of the aortovisceral vessels for potential bypass origins, and to perform the intervention itself. Pre-procedural hydration and meticulous attention to minimizing contrast volume or using CO2 are crucial in patients with baseline kidney dysfunction.
Right, it's more of a pre-treatment planning and treatment tool now. Now, we've talked a lot about imaging the anatomy, the blockage, but we keep coming back to the challenge. Does the blockage cause the problem? That's where functional studies come in, right? What are the options there?
You've nailed a central, pervasive problem in RVD management. We have excellent tools to detect anatomic RAS, but a real lack of practical, reliable screening tests to identify which of those patients with RAS actually have functionally significant disease that will improve with revascularization.
So imaging finds it, but doesn't prove it's the culprit.
Exactly. It doesn't reliably tell us if the RAS is the primary driver of the hypertension or kidney dysfunction. Some things give hints directly measuring the pressure drop across the stenosis during DSA or tracking kidney size loss over time with ultrasound, but they aren't perfect predictors. Radionuclide renography can assess split renal function, potentially showing dysfunction on the side with RAS.
But none are foolproof.
Unfortunately, no single test reliably predicts the response to revascularization. There's active research into newer methods, like blood oxygen level dependent, BLD MRI, or other ways to assess renal tissue ischemia, but they're not mainstream yet. The older functional assays still used in some centers, though their utility is debated, are captive probronography and selective renal vein renin sampling.
Let's take radionuclide renography first. What does that involve?
This involves injecting a radioactive tracer, like technetium-99 Mag3, that's taken up and excreted by the kidneys. A Gamma camera tracks the tracer over time, allowing quantification of how much each kidney contributes to overall function, split renal function, and how quickly it clears the tracer. An abnormal pattern, delayed uptake, or excretion on the side with RAS might suggest a functional consequence.
But it's not always abnormal.
Correct. It's often normal even in patients with significant RAS. And interpretation can be tricky if someone has unilateral RAS, but the contralateral kidney is damaged by hypertension. The defect on the scan might actually appear in the unaffected kidney.
Okay. What about adding an ACE inhibitor, captive probronography?
This test, also called ACE inhibitor renography, leverages the kidney's reliance on Ang2 to maintain filtration pressure when inflow is reduced by RAS. You perform a baseline renogram, then give an ACE inhibitor like captopril or an ARB, and repeat the scan.
What are you looking for?
In a kidney with flow-limiting RAS, blocking Ang2's effect causes a drop in glomerular filtration pressure. This manifests on the scan as a significant worsening, usually a delay or reduction in the uptake and excretion of the tracer by the affected kidney. The contralateral kidney might even show improved function. A positive test, a significant change after the drug, suggests the RAS is hemodynamically significant and potentially contributing to hypertension. A normal study makes clinically significant renovascular hypertension less likely.
Are there limitations?
Yes. It's less accurate in patients with severe baseline renal insufficiency, azotemia, or in very small, poorly functioning kidneys. You can get false negatives or indeterminate results. However, despite limitations, some studies, like one by Erbslow-Mahler, found it had reasonably good sensitivity and specificity for predicting blood pressure response to revascularization, even in azotemic patients.
Interesting approach. Now, the most invasive one, renal vein renin assays. What's the principle there?
The idea is to directly measure renin production by each kidney. If RAS in one kidney is driving hypertension via the RAAS, that kidney should be releasing significantly more renin into its draining vein compared to the systemic circulation and compared to the contralateral kidney.
How is it done?
It requires catheterization. Thin catheters are guided under X-ray into the inferior vena cava and selectively into both the left and right renal veins. Simultaneous blood samples are drawn from both renal veins and the vena cava, representing systemic levels.
Sounds like it needs careful preparation.
Extremely careful. Renin levels fluctuate wildly based on salt intake, posture, medications. So patients typically need strict preparation. Low-sodium diet, stopping most antihypertensive drugs, especially those affecting RAAS, for days beforehand, sometimes diuretic stimulus, and being kept upright for a couple of hours before and during the sampling. Multiple sets of samples are usually drawn over several minutes.
And how are the results interpreted?
The key comparison is the ratio of renin in the renal vein of the potentially affected kidney to the renin level in the systemic circulation vena cava. A ratio of 1.5 or greater is generally considered positive, indicating excessive renin production from that kidney. If the ratio from one kidney is significantly higher than the other, lateralization, it was traditionally thought to predict a good blood pressure response to open surgical revascularization.
But it's not perfect.
No. Failure to lateralize has a low negative predictive value, meaning even if the test is negative, the patient might still benefit from intervention. The contralateral uninvolved kidney often has suppressed renin production due to the high systemic pressure. The test is also less helpful or harder to interpret in bilateral RAS, solitary kidneys, or RAS involving accessory arteries. Its value in predicting response in patients with ischemic nephropathy, rather than just hypertension, is also unclear. Our practice uses it sparingly, maybe occasionally, to help guide decisions about open surgery in clear unilateral RAS.
So functional tests add information but leave uncertainties. It really underscores the complexity of deciding who needs treatment. Okay, let's move into treatment itself. Given everything we've discussed, the risks of RAS, but also the challenges improving benefit from intervention, how are doctors approaching this now?
That's the crux of the current dilemma. We know RAS is associated with high cardiovascular risk, lesion progression, kidney mass loss, dialysis, and death. Yet the benefits of actively fixing the artery with revascularization have been seriously challenged by marked improvements in medical therapy and, critically, by level I evidence from randomized controlled trials, particularly Astral and Coral, that largely failed to show a significant advantage for stenting over optimal medical therapy for many patients with atherosclerotic RAS.
So the pendulum has swung towards medication.
For many patients with atherosclerotic RAS, yes. Most centers now reserve revascularization procedures to the more severe clinical manifestations of atherosclerotic disease that fail medical therapy, or for patients with non-atherosclerotic RVD like FMD.
Okay, let's start with medical management then. What does optimal medical therapy entail for atherosclerotic RVD?
Based on trial data like Coral, medical therapy is the cornerstone. It involves aggressive management of all cardiovascular risk factors and protecting remaining kidney function. First, lifestyle. Smoking cessation is paramount. Regular exercise, healthy diet, weight management if overweight.
What about medications?
Lipid-lowering therapy is key. Monitor cholesterol and aim for secondary prevention targets, like LDL cholesterol below 100 mg/dL, often lower. Antiplatelet therapy, usually low-dose aspirin, and statin therapy are generally recommended for nearly all patients with atherosclerotic RAS, regardless of baseline lipid levels, unless contraindicated.
Statins do more than lower cholesterol here.
Yes, there's evidence statins may slow the progression of RAS itself, reduce restenosis after stenting, and crucially, they provide significant protection against cardiovascular events, heart attack, stroke. The robust medical therapy arm in Coral included widespread statin use and aggressive blood pressure control, which likely contributed to the relatively low event rates seen even without stenting.
Makes sense. What else?
Vigilant monitoring of renal function, using eGFR, creatinine, is essential. Consultation with a nephrologist is important if eGFR is abnormal. Treatment should be tailored to limit further kidney injury, for example. Strict glucose control in diabetics. Target HbA1c, usually 7%. Encourage weight loss if BMI is over 25.
And monitoring the RAS itself?
Yes, annual renal duplex ultrasound is often recommended for patients managed medically, and especially after revascularization, particularly stenting, due to restenosis risk. This checks for stenosis progression or restenosis, vessel patency, and monitors kidney length as an indicator of health. RDU should also be considered sooner if there's abrupt worsening of blood pressure control or kidney function.
Okay, comprehensive risk factor management. What about the high blood pressure itself?
Aggressive hypertension treatment is vital. The BP goals for adults with RVD are generally the same as for essential hypertension. Typically less than 1490 mmHg, perhaps lower, 1380 mmHg, if they also have diabetes or significant chronic kidney disease.
How is that achieved?
Lifestyle modifications are foundational. Sodium restriction, limiting alcohol, stress reduction, exercise. But pharmacotherapy is almost always needed, often multiple agents. While there aren't large trials comparing specific drug combos in RAS, ACE inhibitors, or ARBs, are often considered first-line choices, given the pathophysiology involving RAAS.
But with caution.
Yes, absolutely. Need to monitor serum creatinine closely after starting them, especially in suspected bilateral RAS or a solitary kidney, as they could precipitate acute kidney injury in that setting. If eGFR declines significantly, they usually need to be stopped. Other excellent first-line agents include thiazide diuretics, long-acting calcium channel blockers like amlodipine, and beta blockers. Diuretics are particularly useful for managing the volume component, especially in bilateral disease, but potassium levels need watching. Aldosterone antagonists like spironolactone should be used cautiously with ACE inhibitors with kidney impairment due to hyperkalemia risk. Second-tier agents like hydralazine clonidine might be added if needed, carefully considering side effects.
Okay, so a multi-pronged medical approach is primary for many, but revascularization still exists. When is fixing the artery considered? Let's look back a bit first. How did these procedures evolve?
It's an interesting history. After Ledbetter's 1938 report of curing hypertension in a child by removing an ischemic kidney, nephrectomy, that became a treatment for adults too, but results were very unpredictable. The real breakthrough for repair came in 1954 when Freeman reported the first successful surgical reconstruction, an endarterectomy, that improved hypertension. Then research, particularly by Dean and colleagues, showed revascularization could also salvage kidney function, coining the term ischemic nephropathy and reporting patients coming off dialysis after repair. So nephrectomy was largely abandoned as surgical techniques improved.
But open surgery had its issues.
Yes, open revascularization was effective, but still had inconsistent results for hypertension cure and carried significant morbidity and mortality, especially in elderly patients with widespread atherosclerosis and kidney disease. The advent of better antihypertensive drugs also reduced the pressure to intervene just for blood pressure control.
Then came less invasive options.
Exactly. Andreas Grunzig, the pioneer of coronary angioplasty, also applied balloon angioplasty to RAS in the late 1970s. But results were hampered by high rates of restenosis, the artery narrowing down again. The game changer was the development of balloon expandable stents in the late 80s, early 90s, which dramatically reduced restenosis rates compared to balloon angioplasty alone. This led to a huge surge in endovascular interventions for RAS and a corresponding decline in open surgery. Open reconstruction is now relatively uncommon, mostly performed at specialized high-volume centers.
But then the big trials cast doubt on stenting.
Precisely. Initial enthusiasm for stenting cooled considerably following the publication of large randomized trials like Astral and Coral, which, despite some limitations in their design and patient populations, failed to demonstrate a clear clinical benefit for stenting plus medical therapy over optimal medical therapy alone for most outcomes in patients with atherosclerotic RAS. There have been few small studies directly comparing open surgery to medical therapy or endovascular options. So much of the application of surgery is based on single-center experiences and expert opinion.
So when is open surgery considered today?
Given the lack of level I evidence comparing it to other modalities and the factors we've discussed, its use is much more selective. Our group and others have shifted the primary indication for surgery away from just BP control towards preserving kidney function. We typically consider open repair in relatively good risk patients who have complex disease not easily treatable with stents, for example, bilateral RAS, extensive branch vessel disease, and who have failed aggressive medical management. It's also often the preferred approach in children with developmental RVD.
What are the outcomes like for open surgery now?
Open repair of atherosclerotic RAS generally offers excellent long-term durability, with patency rates over 90%. However, the procedural risks are higher than stenting. One analysis of U.S. inpatient data from the early 2000s reported mortality around 10% for renal bypass, though that seems high compared to specialized center reports. Our own center's published 30-day mortality for open reconstruction for atherosclerotic RAS was 4.6% overall and 7% in the subset with ischemic nephropathy. We found that postoperative renal function was the strongest predictor of long-term survival. Stable or improved eGFR after surgery correlated with better dialysis-free survival, independent of the impact on blood pressure. We also tend to see high rates of BP improvement or cure around 85% with successful open repair of all significant lesions, which is often better than reported stenting results.
Okay, so higher risk but potentially durable results in select patients. What about endovascular stenting then? Where does it fit in now after the trials?
Restenosis after renal artery stenting, while lower than balloon angioplasty, still occurs in over 10% of patients, even in recent trials. Blood pressure responses are variable. And, as mentioned, multiple randomized trials, including the large, well-conducted Coral trial, plus subsequent meta-analyses, have consistently found no significant advantage for stenting, plus medical therapy over medical therapy alone in atherosclerotic RAS for preventing major clinical events, death, stroke, MI, heart failure, progressive kidney failure, or for improving blood pressure control overall.
Were the trial patients typical?
That's debated. The patient demographics in Astral and Coral were somewhat different from historical surgical cohorts, or perhaps even current high-risk referrals, maybe lower baseline BPs, fewer meds. But even subgroup analyses within Coral, looking at patients with more severe hypertension, higher grade stenosis, or chronic kidney disease, failed to identify a clear benefit from stenting. There was a hint that patients with less baseline kidney damage, low urinary albumin to creatinine ratio, might respond better, but that needs more study.
So what's the bottom line on intervention now?
The current consensus, reflected in guidelines and practice, is that most patients with atherosclerotic RVD can, and probably should, be managed conservatively with optimal medical therapy. Intervention, either stenting or open surgery, is generally reserved for patients with severe manifestations of the disease that are refractory to aggressive medical management, or for patients with non-atherosclerotic RVD, like FMD. The choice of which intervention, if needed, depends heavily on the specific arterial anatomy, the patient's overall clinical status and surgical risk, and the available local expertise.
Can you give specific examples of who might still get stented or operated on for atherosclerotic RAS at your center?
Sure, based on the evidence and our experience, we reserve renal stenting or open revascularization for atherosclerotic RAS, primarily for patients who have 1. Failed aggressive medical management, including multiple drugs, of severe refractory hypertension. 2. Experienced a significant, abrupt, and otherwise unexplained decline in eGFR, usually in the setting of concomitant severe hypertension, especially if they have bilateral severe stenosis or stenosis in a single functioning kidney. Or 3. Presented with hypertensive crises complicated by cardiopulmonary or neurologic compromise, like recurrent flash pulmonary edema.
So really the severe end of the spectrum.
For atherosclerosis, yes. However, our threshold for recommending revascularization is considerably lower for children with hemodynamically significant RVD and for adults with symptomatic FMD, particularly those complicated by severe hypertension, because the underlying disease process and expected outcomes are different.
That's a really clear summary of the current thinking. It definitely sounds like treatment has become much more nuanced and individualized. Okay, well, we have covered a huge amount of ground in this deep dive on renovascular disease. Let's try to quickly boil down some of the key takeaways.
Sounds good. I think we've established that RVD, especially the atherosclerotic type, RAS, is a pretty significant condition. It can lead to serious downstream problems like severe hypertension and kidney failure.
Right. And while it's fairly common, particularly as we get older, many people walking around with RAS on an imaging scan might actually be completely asymptomatic.
Exactly. And perhaps the biggest shift in recent years is that for most patients with atherosclerotic RAS, the cornerstone of treatment is now aggressive, comprehensive medical management, controlling blood pressure, lipids, diabetes, and other risk factors.
But interventions haven't disappeared entirely.
No, definitely not. Revascularization procedures, both open surgery and endovascular stenting, still play a crucial role, but they're generally reserved for more specific severe situations where medical therapy isn't cutting it, or for those non-atherosclerotic forms of RVD like FMD.
And it really hammered home just how complex this interplay is between blood flow to the kidney's own function, blood pressure regulation, and overall cardiovascular health. The approach to diagnosis and treatment truly has to be tailored to each individual.
Absolutely. You have to consider the severity, the symptoms, the underlying cause, the patient's other health issues, their response to medication, the anatomy, the risks and benefits of each option.
Yeah.
There's really no single right answer that applies to everyone. It requires careful evaluation and judgment.
So keeping all of that complexity in mind, this intricate connection between our vascular plumbing, kidney health, and overall cardiovascular well-being that we've explored today based on Rutherford's Vascular. Here's a final thought for you, the listener, to mull over. What are maybe one or two of the most crucial lifestyle modifications you could consider making starting today to proactively protect your vascular system and your kidney health long-term? Maybe think about things like diet, exercise, stress, and definitely knowing and managing your blood pressure. Thanks for taking the deep dive with us.